Good afternoon, everyone. We're coming to you live from ESE Paris 2025. Really happy today to have two experts on our panel. Just very quickly to introduce myself, I'm Shalini Kanagasingam from the University of Lancashire, and today supporting the communications team and committee of the ESE, we have with us Professor Shannon Patel, Professor of Endodontology at the King's College London, and also we've got Dr. Hagey Shemesh, Head of Endodontology at ACTA. Welcome, professors and Dr. Shemesh. Thank you so much for joining us today. So, as everyone is waiting for this topic, we're going to talk about CBCT, unfiltered, overuse, underuse, or just right. We're going to take this topic apart. So, can I start off firstly to ask you both to summarize when do you think CBCT is absolutely indispensable? We definitely need to take it. When would you think maybe a situation it might be optional? And are there any actual contraindications, situations where you think we shouldn't be scanning? Would you like to start, Shannon? Or yeah?
Okay,
Yeah.
okay, thank you. For me, cone beam CT is essential for every case.
Every case.
Every case. If I have a patient referred to me for endo,
Yeah.
I scan the patient. Full stop.
And you've been doing this for, I think you started CBCT, what, 19 years
I've been
ago?
using
Back
cone
in,
beam
yeah?
CT since 2006.
Yeah.
Initially, just for challenging cases.
Yeah.
But then I found that all cases were challenging. So
Yes.
since 2010, I scan every single case. Do you use a microscope for every single case, even the simplest upper central incisor?
Yes.
Yes. Why?
To
It
do
enhances.
optimal.
It's
Yeah.
the same with cone beam CT.
Yeah.
You may be confident with your diagnosis, but it may have an impact on your management.
Right. Thank you for that very honest answer, Shannon.
Thank you.
Hagai, what do you think?
So I think differently, of
Yeah.
course. I think that there are no really contraindications.
Yeah.
So here I agree with Shannon completely.
Yeah.
Maybe you should be careful with pregnant women or children, but also in these cases, I can imagine some indication which should be where CBCT should be used. However, I think that you have to have a clinical question first before venturing into a CBCT because it has extra radiation for the patient, and costs for the patient. So I think, and if we follow the guidelines also, we see that there are specific indications where CBCT is maybe beneficial, but I don't think it's for every case.
Right. So if we talk about the guidelines, do you think they are actually covering? Do you think there's a chance to update? I think both of you involved. Shannon, lead author for 2019
Yep.
ESE guidelines for CBCT indications.
I think the guidelines are just guidelines.
Yeah.
It's advice for endodontists and general practitioners. And we mentioned in there, you've got to optimize or justify, optimize before you take a scan.
Of course.
Just like you would with the radiograph. But for me, endodontics is complex. Every single case is complex. So in the guidelines, we talk about taking CBCT for complex cases.
Yeah.
So I need all the help I can get. So that's why I take a scan.
Okay, what do you
so
think?
I think that if you look at the guidelines, first of all, most of them are not guidelines, but are position statements, which is a little bit different than guidelines.
Yeah.
The only guidelines, the real guidelines that we have is the S3 guideline from 2023. They are very strict indeed. So here I agree a little bit with Shannon, because they are so strict that they actually cannot recommend CBCT for any case, because they only look at the influence of CBCT on the outcome. So in this case, we have a problem there. So I think that the guidelines are too strict. However, I'm concerned with people who are so enthusiastic about CBCT that they overuse the CBCT and they do some scans that are not justified, but especially are not done according to the optimized manner that CBCT should be done. And then the patient is exposed to radiation, pays the price, but you can't use the CBCT. So tomorrow I will show in my presentation a few of these cases where CBCT is actually being abused by some professional, and this is my concern here.
Yeah, I mean, you've raised some valid points there, and I do agree with you, but you've got to put this in context. These clinicians who are abusing CBCT, who are overusing, maybe misdiagnosing, maybe overtreating like you'll show tomorrow, that's basically, I think, down to inadequate or lack of training. What's happening is they see someone like you talking about cone beam CT, and they say, right, I need to get a cone beam CT scanner. They buy a cone beam CT scanner. They don't get proper training. The manufacturer gives them some generic,
sometimes you actually get the
very,
training
very
from the
wishy-washy
manufacturers
training.
themselves. Yeah.
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 And then they're driving without a license.
Yeah.
Yeah. Before you can start using cone beam CT, you need to get really good training. Okay, you need to get good training, and then ideally you need to be mentored. You need to go through cases with a colleague. You can't just jump in.
Yeah.
So it's the context.
How does it work across Europe? Because in the UK, we're familiar with making sure that we must have level 1, level 2 training in order to not just indicate for CBCT, but also prepare interpretation and a report. So in Europe, is it the similar expectations of a clinician?
I cannot speak for Europe, but for
Yeah.
the Netherlands, we also have
Yeah.
this compulsory training.
Yeah.
But I wonder, how is it being implemented, or do we check every time that we get a referral for CBCT if this person really is has this training?
Yeah.
So I don't know if it's really being implemented. But yes, we have this, and this is an important issue that I agree with.
So in the UK, everything is heavily regulated, as you know. So in the UK, you need to have level 1 and level 2 training, which is about 24 or 28 hours of verifiable CPD on CBCT. So, by the time you've got level 2, you should be competent, and you shouldn't be overusing, underusing, undertreating, overtreating. You should have adequate knowledge to use CBCT.
In your opinion, because you said there were no contraindications, I get where you're coming from. But if you had a tooth that was perhaps next to an implant, or a tooth with heavy metallic restorations, metallic posts and such, do you think it's justifiable to expose that patient, knowing that you may have a problem with the artifacts? And also, maybe you might also tell me, what is your opinion on these artifact minimizing sort of systems that are in CBCT systems now? Are they useful? Are they effective? Do you have an opinion on them?
So you're asking several questions in one question.
Yes, many questions. Yeah.
So
You
the
can take
first
them
question,
one by one. Yeah.
So taking a scan with someone with a lot of metal in their mouth, that's what you're asking.
Yeah.
Would I take a scan? Well, you've got to put this in context.
Yeah.
It's to do with your training, justifying optimizing a scan,
Yeah.
but the scanner you have. Okay, so if you've got a really good quality scanner, what scanner do you have?
Morita.
So we either Morita as well.
Okay.
So something like the Morita is where you can adjust exposure parameters. You can increase the MA. You can so you can get a better quality image. Now, someone will say, well, if you're increasing the MA, you're going to irradiate your patient. But a patient coming to see you with implants, post crowns, they're not going to be radiosensitive. They're going to probably be in their 50s or 60s. They're not going to be a child or an 18-year-old. So you've got to contextualize it. So if someone's coming in with implants next to a root filled tooth, you ask your radiographer to increase the MA. But again, it goes down to the scanner as well, because if you've got a really poor scanner, then there's no point taking the scanner. I'm very spoiled. I've got, in my opinion, the best scanner on the market. So, I know how to use the exposure parameters, because I tailor each scan to the patient and the needs I want. Whereas if I had a Mickey Mouse scanner, there'd be no point, because most of the scans would be of poor quality.
Yeah.
So, you've got to put it in context.
Hagai, what do you think?
I don't think it's a contraindication if you have an implant nearby, but you do have to know what you are doing. Again, you do have to have a clinical question. You do have to take consideration about all the structures nearby and how do they influence the quality of your scan. You have to take account of the possible algorithms that you may use to improve the quality of the scan and the machine, like Shannon said, and then you can indicate a scan, but not automatically.
Well, I agree, but if a patient's coming in with an endo problem, you do your clinical examination, then you need to take an X-ray. So the scan is like an X-ray. It is an X-ray. It's just a 3D X-ray.
But it has a high exposure to radiation. It's much more expensive.
Well, put this expense on one side, but you're irradiating to your patient a little bit more. But give me the evidence that dental radiation causes cancer, causes any problem. There is no evidence. The amount of radiation, well, I took the train here, but the amount of radiation I get when I fly to the south of France is far higher than a small field of view cone beam CT scanner, or the amount of radiation that we're exposed to when we are sitting in the sunshine in our summer holidays. So you've got to put this in context.
That's
everyone's, there's all this fear mongering about radiation. And if you look at I think the American Association of Medical Physicists mentioned it in a statement, position statement a few years ago. They were like, there's no contraindication to taking any sort of dental X-ray. You're not going to get cancer. You've got to put this in context. Patients aren't coming in for full head CT scans for a whole month. Then you're going to probably have problems. But what we're doing is really, really, really minuscule, really, really minuscule. A handful of Brazil nuts, you get about, I think, 8 microsieverts of radiation.
How many bananas is that?
I think 1 or 2.
Yeah.
What
do you think? Okay, yeah. I mean,
I think
right?
we have
pragmatism
to avoid overexposing patient without the need. Again, it's all a question of indications, and if it is needed, it's not only the question of radiation. It's the question is what kind of extra information you get if you radiate every patient. If you actually prescribe CBCT for every patient, we wouldn't need any guidelines because we just do the CBCT. So we don't need guidelines and we don't need indications. We don't need any of this because you just make a CBCT for every patient. And I understand the point. It's a dilemma, I understand, because what Shannon says, I think, is that if you don't make the scan, you don't know what you miss.
Yes.
So actually, you don't know what you miss. And this is a point that he's making. He has a point there.
And medical legally as well. Sorry to say, but I think that is an important issue that you've mentioned.
But it's not just what you may miss. It actually, there's evidence to show that you are more confident about what you're going to do. In fact, we published a paper recently. One of our postgraduates, James, published a really, really nice paper looking at the use of cone beam CT in the UK. And now there is overwhelming evidence to show that we're using it even more and more now. And one of the reasons we're using it is it makes us more confident about what we're doing. Now, if you're more confident about what you're doing, you're going to execute your treatment in a better way. So, hypothetically, your outcomes are going to improve as well.
This has to be proven yet, if the outcome indeed is better when you have a CBCT. But I agree with you that there are some groups around there, and I know I'm one of them, that tries indeed to show this. And it could be that we'll see it in the future. So I do believe that in the future, we'll more evidence to use it or not to use it in certain cases. That's true. But still, I have a problem with an automatic prescribing CBCT without having first a clinical question.
Yeah.
And I think that the guideline supports this.
What about issues such as trauma? So patients already uncomfortable, and I think many of us have struggled actually, to even try to get an occlusal film into a patient's mouth at that time. Do you think, for instance, the trauma guidelines are also quite conservative in terms of how they, actually recommending 3D images? Where do you stand with that, Hage, for trauma?
I think the trauma is one of the indications that I do CBCT in many cases. But of course, you have to be careful because we usually speak about children, sometimes young children.
Yes.
But again, I think that CBCT here can give a lot of important, sometimes crucial information, but again, not automatically.
Shannon? Yeah.
So the IADT guidelines, I'm not sure if they're still, if I'm correct here, if they've changed them or not, but someone comes in and they've traumatized their upper anterior teeth. They're suggesting 5 periapicals, 3 of the centrals, 2 of the laterals, and an occlusal radiograph.
Yeah.
Okay, how accurate are these images we're producing? Do they really represent the anatomy? Even if you use a beam aiming device, they're not parallel. Teeth aren't straight, and you're in the palate. So actually, what I do is I don't take any plain films. I just take a scan, because I have never, hand on heart, I've never taken an occlusal radiograph. I think it's the most pointless film you can take.
And sometimes
Okay.
we're made to take an occlusal radiograph with a rectangular collimator.
It's madness.
There are some schools doing that. It is
a small,
very tough.
small field of view scan.
Yeah.
But what I do when it's children or
Yeah.
adolescents is I reduce the MA or I do
Yeah.
a 180 because all I want to see is macro anatomy. I want to see if there's a fracture. I want to see if the cortical plate is fractured and so on. So, and also with the scout view, you can see if there's any tooth fragments, bits
Yeah.
of pavement or whatever in their lips.
Yeah.
So, and it's extra oral. So someone comes in, they've traumatized their teeth. How are you going to get them to bite on a beam aiming device 5 times?
Especially a child. Sometimes it is a bit
Not
more
even
traumatic
a child, even an adult.
an adult who is still in pain.
It's really traumatizing. You know, you mentally, you know, you've broken your front teeth, and someone goes, right, I've got to stick this in your mouth. Take 5 different X-rays. Oh, hang on a minute, I've got to put this occlusal radiograph in there as well. It's crazy.
But
So maybe the guidelines should be changed.
Yeah,
That's
do you
true.
think?
But still, I want to draw your attention to the
Yeah.
fact that we're talking about small children
Yeah.
and exposing them for CBCT is something that we have to take seriously. And of course, weigh the benefits against the risks. That's all.
And probably still start with the periapical, because again, I'm trained to always at least start with the 2D.
I trained you. Excuse me.
The position statement still says 2D first
you do,
before we
but
go 3D, Shannon.
yeah,
So
we do. But I mean,
you wrote that, you know?
I just do things slightly different. I just don't see how if you've got a 3D scan that shows you you can orientate the tooth so accurately you can see how long it is. Why do you need a radiograph of a child?
Sometimes
my daughter, she traumatized her teeth, and my wife's an orthodontist, and she was quite sort of she takes your approach, and she said to me, look, we've got to take a radiograph. And I said, if you want me to see our daughter in the practice, we'll do a scan. We're not going to do a periapical radiograph. And I just reduced it from a 360 to 180. I reduced the MA to, I think she was about 7 or 8 at the time, but I reduced the MA to, I dropped it by about, I think, 1 MA. And then I worked out the radiation dose, and it was equivalent of 2 periapicals. Okay, so I took 2 periapicals for that cone beam CT scan. How much more information did I get? And also, what we haven't mentioned, I'm sure we will in a moment, is you take a scan. What happens is you reduce the number of intraoperative radiographs you take. You have a complex tooth, lower molar, and maybe there's the ledge. You think there's a ledge. And you've actually got a scan and you realize actually there's an abrupt curvature in the buccolingual plane. So what I found is I now just take 9 times out of 10, I take 1 intraoperative radiograph. That's a master point radiograph, which has already got cement on it. And I only take that radiograph because medico-legally, I need some evidence to show I've done a working length radiograph. That's the only reason I do it. Whereas historically, when I was much younger, say several decades ago, I would take a working length radiograph, I would take a midfield radiograph, I would take and you reduce your treatment time because before you put the burr on the tooth, you know what the problems are, you know where to go, where the canal bifurcates, joins, how close it is to the IDN. How many times have we done an endo and the root apices are sitting on the lingual plate, the lower 7? And then you're like, actually, you show the patient, you go, look, I'm deliberately going to prep and fill 1 millimeter short. Why am I going to do this? Because I don't want to create a hematoma here, and don't want you phoning me up on Friday night.
So going back to the children,
yes.
Again, I'm sure that Shannon does it in a very responsible way. He is very knowledgeable, so he probably knows how to lower, indeed, like he said very nicely, the level of radiation. So I trust him completely, and this is very good what he's doing. And we should all have the knowledge that he does.
Thank you.
Yes.
You have a lot of knowledge as well.
At the same
you're
time,
my favorite endodontist, by the way.
Thank you.
Duly noted.
Thank you. At the same time, sometimes my problem is we're doing it automatically. Sometimes when you take an X-ray, sorry, Shannon, old-fashioned X-ray, you can make the diagnosis without being without the need of CBCT. So this is my problem. When you need the CBCT, of course, by all means, make it, even with children. I agree. Lowering the radiation as you explained. But sometimes I can make the diagnosis with an X-ray. So, and we have experience with that for many years and still. So that's my problem, that the automatically jumping immediately to CBCT without having first the knowledge of what's going on, this is what I have difficulties with.
Okay.
Can I bring up one
No,
just
no,
one
one
issue?
more. No.
Okay.
It's really important. Let's put this in
Yeah.
context. I'm advocating taking a scan for each patient.
Yeah.
However, I tailor the scan to
To the
the
patient.
needs, my needs, and the
Yeah.
patient. Okay. I am always telling my radiographer what MA I want. If it's a 180, a 360. If I have an old lady, sure, I rephrase that, an old person coming in
Yeah.
with a little tremor, I do a fast scan.
Yeah.
Right? You have to you've got to optimize the exposure parameters. Okay, so that's really, really important. And that way, you're minimizing your radiation dose. You're getting more information from the scan. Now, talking about the diagnosis, you said, you can take a radiograph and you can confirm your diagnosis. 9 times out of 10, we know what the diagnosis is before we take the radiograph. Before we look in the patient's mouth, we know what the diagnosis is. We ask the patient loaded questions. Now, let's say, I know the diagnosis most of the time with the radiograph, but what the scan is doing is either making me more confident about my diagnosis, or it's having an impact on my treatment plan, whether I do surgery or non-surgical approach. Yesterday I spoke about external cervical resorption. The first in vivo study on cone beam CT was by me decades ago, 2009, and we looked at root resorption. Okay, so with external cervical resorption, you take a radiograph, you've got external cervical resorption. But are you going to manage that externally or do an internal approach? You need 3D imaging.
But
So
Shannon,
you know what
if
the
it's
diagnosis.
lost, if it's lost,
You know what the diagnosis. No. If you're going to consider treating it.
oh, okay.
If you're going to consider treating it,
Right.
yeah. And you look at the evidence. So there's not just my research, but if you look at Francesca Bella's group, when they took a scan, the extraction rate increased. So they're reducing the amount of treatment they're giving their patients. They're not over-treating their patients with scans. Yeah.
Can I just bring up that point as well? So you've mentioned again, from your both of you have obviously high expertise. You know what you need to do to adjust parameters of a scan.
That's essential. It's essential.
But we are not taught that. And also, I'm not sure if there's actual sort of if you talk about guidance.
Well, you should be
on
in your
how we
level
should
2.
adapt that.
Level 2 training
Yeah.
is all about optimizing your scan. So someone comes in, they've got this problem. What type of scan do you take? How do you increase? Do you need to increase exposure, reduce exposure? What do you do?
Do you think it's time for maybe the ESE, has a role to perhaps bring this into the forefront and make it a bit more prescriptive
I
to
think we
help
both agree on that.
clinicians?
Yes, of
Right?
course.
Because
of course.
we are just following manufacturer's instructions.
Yeah.
I take my own scans.
I don't.
I think a lot of dentists out there who have scanners, we following the manufacturers, how they ask us to position patients, how do we may not be able to freely adjust these parameters without actually written guidelines for as such.
There is a new publication just published last month from Reinilda Jacobs from Leuven and her group with recommendation what kind of parameters should we pay attention to the scan. I will present it tomorrow in my talk.
So we look forward to that.
There's some basic things like before you need to even position the patient's head properly. All these subtle things to improve the diagnostic yield. And it's the level 1 and level 2 training. But the ESE has a responsibility as well because, endodontists are using cone beam CT more and more often now. So I think we do need to upgrade.
And perhaps maybe the ESE could collaborate with the AAE so that we all have, one.
That's asking for too much.
Too much.
We try.
But we were the first. We were the first to publish the guidelines, and the Americans were after us.
So it's a good position to come together now, right? Yeah. So I'd like to go a little bit more now into, again, dentists are always being sold also different softwares for CBCT interpretation. Also, some of these filters that people pay a lot of money for. Is it worth it? Do you think, does that really make a difference? I know you can only say in your personal opinion if you've used these. Do you think it changes the way should we be investing in these at all?
I know that some of these algorithms or filters are there.
Yeah.
Some of them are embedded in the machines already. Again, the article I was discussing about talks about some of these filters, but you see that you have to switch them on for all cases. So I don't understand exactly where they are different from each other and what kind of additional information they can give us. But I guess time will tell. Maybe you have more experience with that.
My opinion is just do the basics properly.
Yeah.
I don't have much. I've used a few of them, but my impression or my opinion is just get some good training, learn how your scanner works, and learn organically. Just do the basics correctly first before you start jumping into secondary software
Yeah.
or filters. Just like with a radiograph, do you use filters and algorithms? Or no, you learn about how to take a good radiograph. You learn about the limitations of the radiograph, and then you can contextualize what you're seeing. So for me, I just do the basics. I'm a very simple person. I can't do anything complicated.
Okay.
Yeah.
That's good advice. But also there are obviously AI is coming up now. You've got, software like DiagnoCat, which are giving you the interpretation.
I think it's,
How
it's
reliable at
helpful.
this?
I think it can be helpful,
Yeah.
but you can't rely on it. That's my
Exactly, I
opinion.
agree, because
Yeah.
there was now a presentation
agree.
about this.
We
This is a
agree.
good
Class.
way to go. Yes,
So-
that's agreement.
So I think the AI is a promising way to go,
Yeah,
but still,
yeah.
we just saw a research project from London, by the way, looking at the reliability of these AI programs to diagnose periapical lesion, and it was not amazing. So I think it could be helpful, of course, but it could not replace the clinician yet.
Of course.
I think in the future it's going to be very, very useful, but it's essential that the clinician knows how to interpret a scan.
Yeah.
You can't just start jumping in and using these very sophisticated algorithms, softwares, AIs, and whatever. You need to do the basics properly.
I suppose as endodontists as well, we mustn't forget the role of the dental-maxillofacial radiologist. We may need to also then refer certain cases for second opinions where
100%,
need be.
yeah.
So, and not just rely on our expertise.
But actually, what we haven't spoken about, and again, I think Hage, you and I will agree, as endodontists, we should be taking high resolution, small field of view.
Yeah.
There is no middle or large size. You should not. I mean, how many times do I get a patient coming in and they say, "Oh, I've got my own scan," and then my assistant rolls her eyeballs, she puts it in the machine, and then this, not even a whole arch, a full head.
Yeah.
And none of it's been reported on. So it's incumbent on us to use a small field of view, high resolution. So it's like a periapical with depth. The best people to interpret periapicals are endodontists. I think we agree. So small field of view, the best people are endodontists. If there's something on the scan that you're not confident with, or you want to get a second opinion, you get a maxillofacial radiologist to give you an opinion. 100%.
Agreed.
And that's also in the guidelines.
I will just add one thing.
Yeah.
If there is an indication for a CBCT, then the CBCT, of course, has to be small field of view and high resolution. Absolutely.
So we agree. That's twice.
Sort of.
I think we're running out of time as it is, but I would like to end maybe just getting both of you to give me your opinions. 5 years' time, where do we stand with CBCT? Where do you think we're going with the technology? What can we expect to improve maybe our lives as clinicians? And one more small thing I might just ask you to comment on is also MRI versus CBCT. What do you think? And then, I asked many questions in one go. So, please go ahead.
I'll answer the first question and Hage can answer
do
the
the
second
MRI
question.
one. Perfect. Well done,
So
Shannon.
in 5 years' time, I would have retired. So I don't really mind what you do.
We might see you in the lecture circuit, in another,
No.
Yeah, but so you were going to tell us the future of CBCT.
I think, well, it's exciting. We're going to be using it more and more. But what we'll find is the radiation dose will be lower.
Yeah.
The quality will be better. And it will just be easy. And the software will be easier to use. So it's exciting. If you look back when we started using CBCT when we were in our 20s, Hage, the quality wasn't that great and people weren't using it that often. But, you fast forward to now, quality is better. People understand the scans better. Do you remember 15 years ago, I'd get a phone call from an endodontist saying, "Oh, can you look at this scan? I think this root field tooth is cracked." And I would be like, "No, it's just beam hardening."
Yeah. Artifacts.
Yeah. And now they're understanding things better. So it's improving and improving, and it will only get better.
I hope it will be integrated more into education. So I hope that the undergraduates will take a course in CBCT and the postgraduate will get more and more trained and be experts in reading and performing CBCT. So I see it already in our school. I see it in the guidelines of the ESE for undergraduate studies. It already appears in the new ESE guidelines for undergraduate students that it has to be also taught in schools, in dental schools. So this is where I hope the future will bring us.
I think that's an important point because our undergraduates actually are excited about the technology. They want to be part of it or be able to at least indicate for it. So Shannon, you agree? Undergraduate curriculum
I agree.
probably needs a shake-up for a bit of CBCT.
I wouldn't say shake
No?
up. I'm sure it's quite good already. I don't want to upset people, but I think what we need is we need undergraduates to understand what code use. Level one. That's what they need.
Level
but
one.
as we've alluded to, it's all about justifying and then optimizing.
Yeah.
And also don't get sucked in with what the manufacturers say. You've got to learn about the scanner. You've got to choose the scanner correctly. So they do need to know the basics.
I'll let Hagai say the last words if you want to compare CBCT, MRI, or what your opinion is for CBCT's future.
Well, I heard a lecture yesterday about this, and I know that in our school they're busy with seeing the possibility of MRI in endodontics. It's very promising, but there is still a lot of work to do. It's very expensive. I don't know if it's chair side already. And it is promising because it's not with radiation. There is no ionized radiation, but it's very expensive, and I don't know exactly what are the indications, and we have to see what are we seeing actually. So there is a lot to do, but yes, it's very promising and interesting. Absolutely.
Thank you very much. So I think with that, we bring our live session to an end. Thank you so much to our expert panel of speakers. Yes, thank you. And we look forward to the future sessions. So thank you for your attention.